I love you. I love being here with the ICPA. You guys are amazing, and you're doing the work. And we're all about helping our babies. We're helping our mothers. We're helping our families, our fathers. We're helping all the birthing people in this country and in the world become better people. And what we do matters. You matter, your hands matter, your brains matter, your love matters. So thank you for being here today. I'm Dr. Kristen Hosaka, and I'm all about birth and babies. I love them. But what really gets me is fetal malpresentation. It's something we should all be aware of because that's where the first subluxation happens. When our babies are in funny positions, they grow in funny positions and their fascia becomes restricted, and the subluxations are created in those first moments in utero. Whether it's chemical, physical, or emotional, we all have subluxations that we start with from the get-go. So what is fetal malpresentation? Oops, let me figure out how to work this. Fetal malpresentation is anything where the baby is not in a left-lying position as they get ready to come through the birth canal. I forgot my baby. Matt, would you grab my baby out of that bag right there? How could I forget the baby? Oh my goodness. My baby. So, when our moms are getting ready, oh, thank you. So when our babies are getting ready to come through the birth canal, we would like for their back to be on the left side. We've all heard that, of course, breech is a malpresentation, but if they're on the right side, that is the next level of malpresentation. And then we have OP, and then we have left-sided, and then we have asynclitic or nuchal hand presentation. It's not just baby being head down. When the hands are in the way, they can cause the head to be tilted. If they grow with a tilted head, they're going to come out with cervical subluxation. If they grow with a tilted head, they are going to come out with cranial subluxations. So how can we prevent this? We balance our moms. We balance our birthing people because our babies occupy the space that they have. Where they grow, that's how they're going to grow. We have interuterine constraint. They occupy the space. If our moms are constrained from stress, from poor eating habits, from emotional dysregulation, our babies will be constrained. If they overwork their bodies and they're super tight, our babies will be constrained. Now, I'm a stalker on Facebook and Instagram, and I see these women that, oh, look at my abs, I'm 9 months pregnant, and look at these six-pack, which I will never have, but anyway. So I stalk them, and I look, and I see what their births are like. And most of them have C-sections, and their babies come out with head tilts and torticollis. They're too tight. So what can we do? We do what we do. We do Webster, we balance their fascia, and we reduce those subluxations before they start. This is a great study. This is torticollis, facial asymmetry, and plagiocephaly in normal newborns. Normal. They don't have anything wrong with them. I beg to differ. But 73% of newborns in this study had one or more asymmetries. 73% of normal babies. Our women are constrained. What can we do about it? 16% had asymmetry of the mandible, 13 facial asymmetries, and 42% asymmetries of the head and torticollis. All of these things are things that they're a wheelhouse. So we need to be seeing the babies, but we need to be preventing this before it happens. And this is just a great picture. We can actually see the cranial asymmetries in this young one. So I'm a big fan of Dr. Carol Phillips. She's my genie. I didn't get to know Jeannie like the rest of this crowd has today, but Carol's my Jeannie. She says that an imbalance in the mother's structure may tip the uterus, resulting in the structural imbalances within the baby's body. This will make it difficult for him or her to maneuver the birth canal easily and safely. So as our babies are coming through the birth canal, they must go through the cardinal movements of birth. When our mothers are constrained, they do not go through this process. This is the first integration of our primitive reflexes. We want our moms to have a normal birth so the baby's brain begins to develop in the way that it should. And I'm not a neuro person, I'm not a primitive reflexes person, so I can't give you all those details, but I know that when it doesn't happen, we have to go back and do the work. We have to go back and help them integrate these reflexes that they didn't start with when it didn't occur in their birth. We have to make this happen. And we can see we have a lot of visual information about fetal malpresentation. I did not take this x-ray. Please do not stone me. I did not do this. This is one of our OBs in our area would take an x-ray before he would do an ECV, and I'm just grateful to have it because it shows exactly what this baby is doing in utero. That baby, he had one hand in his mouth and the other arm behind his back. What kind of subluxation do you think is going to happen with this child? And his feet were tucked up in the mom's pelvis. Now, I didn't know what was going on with the presentation of this child, but I could see in her abdomen, without even doing a UT angle, that something was off. And John's work is great on that. But she was riding high. She walked in the office. We knew something was out of alignment with the baby. And when he came out with fascial restrictions. Do you see the picture? It's the same as the x-ray. That's how he grew. That is his spinal pattern. That is his fascial pattern. That is something that we have to take care of once they come out. Same person, different photograph. What they do in utero, they do when they come out. So if you're seeing someone and you're not sure what they did in utero, look at how they sleep. What is their position of ease? They're going to show us. They're going to show us their fascial patterns. They're going to show us that they had a nuchal hand that caused the 36-hour labor, or an asynclitic head position that caused them to be in labor for days and days, instead of the 6 to 8 hours that would be a normal labor. So when we start to recognize these patterns in our babies, and this is how I came up with my nuchal hands information, I started seeing the babies come out, and I'd ask them about their labor patterns. And they had similar signs and symptoms during pregnancy. It hurt right here, and it didn't correct with the adjustment. It hurt right here, and they'd get up off the table, and it would be fine, and they'd take a step, and it would come back immediately. Because it wasn't their subluxation pattern that was causing their pain. It was the baby's in utero position. And when I would see these babies come out, and they would have a hand by their head, I began to put these signs and symptoms together. And we can see this in our office. And there's things that we can do. We can up our care plan. We can have them do the spinning babies techniques, which are really Dr. Carroll's techniques. Yes, 100%. Side lying release and forward leaning inversion, if you don't know, those are chiropractic techniques. Dr. Carol Phillip developed those many years ago, and she gave them to Gail for us to share, for Gail to share to the world. So we appreciate that, but they are chiropractic techniques. So what are the effects of malposition? We're going to see increased injury to our babies and to our moms. Increased chance of tearing, increased chance of brachial plexus injuries. Their cranial plates may be overlapped and subluxated. Subluxation, absolutely, 100%. These babies are going to come out subluxated. They may have torticollis. They're going to have fascial restrictions. And they're going to have a hard time nursing, or a harder time. They may be able to compensate. Depends on how severe their subluxations and their growth patterns are. And then we're going to see an intervention cascade. We're going to see more epidurals, more Pitocin, more C-sections, more trauma and PTSD and postpartum depression, because all of these things go with a hard labor. My first child, she was born with a nuchal hand. I tore, 3+ tear. It was bad. I couldn't sit down for a while. But I had depression, and what was wrong with me? Because my labor hurt so bad. And we're made to do this, but why couldn't I have that easy birth? Why did the pain get to me so much? And years later, I found out it was because she had a hand up there. And that's like your uterus contracting around a Lego, okay? Lego contractions. Your patients will get that. Your clients will get that. But it's true. That hand hurts because it's asymmetrical. And so if we have our moms coming in and their contractions, their prodromal contractions are hurting and they can pinpoint areas of pain, that baby's in a poor position. And there's more we need to do. There's more that we can do to help that baby get into a better position and have a better start to its life. Breech. We're going to see more hip dysplasia. Look at that baby's head. That is a typical breech head. That's what they look like. Once you get into cranial work, if you haven't already, once you start seeing these typical patterns, you're going to be able to look around the room and go, oh, you were a posterior baby, weren't you? How was your birth? Oh, 40 hours. Okay, you're poor mom. That's my husband, by the way. 40 hours of labor. He's got a flat head. Looks just like every posterior or baby that I've ever seen. But you'll begin to see these. And all of these things occur because there are fascial restrictions and torsions in the pelvis. There's subluxation of the tissue and the bony structure within the pelvis. There's usually a neurological component to it as well, because what we see in the pelvis, we see in the cranium. They work together, craniosacral. And when they're not in balance in the head, you're going to see it on both ends. Now, these are just pictures. I Googled jugular foramen, and I just picked a few of these. Look at the birth trauma and the cranial compression at the differences in the jugular foramen from side to side. They are different on each side. What does this set you up for in your lifetime? Jugular foramen, suck, swallow, breathe, vagus. What does this set you up for? Breastfeeding problems, anxiety, depression, all the things. Dysregulation of your autonomic nervous system. And this is from fetal malpresentation. Because when our babies are in a poor position, they have birth trauma. So vagus nerve, John's going to talk about this. I'm just going to touch on it. What do we see in our babies? They're unhappy. They have nursing problems. They have cranial restrictions. They're colicky. Their lambdoid suture is going to overlap down here. A lambdoid decompression can 100% change somebody's life. And I say that because it changed my son. I spent 18 years looking for a reason why my son was the angry child, why he was Jekyll and Hyde, why we got phone calls throughout his life from the school, why he dropped out of school and turned to bad things in his life. And finally, Dr. Carroll adjusted him, and he had seen other chiropractors throughout his life. When he went to a seminar, what am I missing? Can you adjust my child? And Dr. Carroll released his lambdoid suture, and he hasn't called me again at 3 o'clock in the morning telling me that he wants to kill himself. Not since Dr. Carroll did her work. And the lambdoid suture is going to freaking change a life. It's going to save a life. And if you can get to it when they're a baby and help these moms and these families, you're going to change their entire being. And I wasn't going to talk about him today because it's so much. But what we do is real, and it's important. And we have a beautiful job, and we can save these lives. So what are we going to look for? We're going to look for body awareness. How are your clients showing up? How are your practice members showing up? Do they have pain points? Are the adjustments effective in reducing their pain? And I don't like to chase pain. I don't want to do that. But in a pregnant person, pain signifies dysfunction because pregnancy should not be painful. Are our adjustments correcting this pain, or is it still lingering? And if it's still lingering, we have to look at, is it from the birthing person, the pregnant person, or is it from the baby? Because a baby can change a subluxation pattern. A baby can change the listing of the sacrum. Okay. We can look for an asymmetrical lie of the fetal head. When we're palpating those round ligaments, is that head centered? Or is that head off in their hip pocket? They're like, it's just so heavy over here. Where's the head? And I'm not telling you to palpate the fetus, but ask them. They come in, they say, yeah, baby's really heavy, or no, baby feels pretty centered. We can ask questions. We don't do the obstetrics. We don't go outside of our scope unless maybe you have a PHA. That's a pretty good idea, Jay. I love that. But what questions can we ask? Where are you getting the big kicks today? Are they all on the right? Are the flutters on the right? If you have kicks on one side and you have flutters on the other side, something's wrong with that baby. It's in a bad position. It's either got a hand behind its head or it's twisted. And either one of those is not good. We can look for asymmetry of the uterus. Is the uterus kicked off to one side? Is it round and beautiful when they walk in, or is it flat? And, are you pregnant, or what's going on here? Is it high? Is it low? Look at that UT angle. And, a lot of that is just visual inspection. I don't really take angles. I just kind of look. We can look at their pelvic patterns, their uterine patterns, and then are they having focused awareness during contraction? Is it easy? Is it symmetrical? Or is it the Lego contraction? Does it hurt here and here? Prodromal labor. Prodromal labor is 100% the body's way of trying to move the baby into a better position for birth. We have our Braxton Hicks practice. Our uterus gets some, a nice little workout. But prodromal is the body's way of trying to move the baby. We have innate intelligence. It's beautiful. It does its job. And let's help it. And then there's asymmetrical movement of the sacrum during labor. The sacrum moves with every contraction during labor. It moves up and down. And if it's not doing that, you've got something else going on. You have restriction in the SI joints. You have nuchal hand. You have asynclitic. Or maybe they're just constipated and they got a lot of bowel that's holding that sacrum down. But it will move with every contraction unless there's something off. And we can figure those things out just by feeling and being with the sacrum when that woman is in labor. So those are our indicators. It's our jobs to facilitate a well-adjusted birth and a subluxation-free life. Y'all are doing the work. We're doing this together. We are making a better world for each other and our children and our grandchildren. So thank you all for being here, and keep up your amazing jobs.
Watch them grow.